Hi, my name is Dr. Toby Moma. I'm a family physician, assistant professor at the University of Mississippi Medical Center, and it's a joy to ask you to join us on our show, Health and Wellness with Dr. Toby. This week, we have a great guest. His name is Dr. Femi Ogundeji. He's an addiction psychiatrist at the Brentwood Hospital of Psychiatry in Shreveport, Louisiana. Been with them for 6 years, trained at the University of Ilorin, Nigeria, Drexel University for his psychiatry residency, and then went on to do 2 years of addiction psychiatry. He's one of the few addictionologists in the state of Louisiana. He's going to be sharing his experience treating gambling, treating sex addiction, treating cocaine abuse, treating marijuana, ADHD, stimulant abuse, treating children, adults, pregnant women. He has a multi-specialty experience, and you don't want to miss it. Look forward to seeing you on the show. Jesus is Lord. God bless you. My name again, Dr. Toby Moma, your host on Health and Wellness with Dr. Toby. God bless you. Hi, this is Dr. Toby, your host on Health and Wellness with Dr. Femi Ogundeji from the Brentwood Psychiatric Hospital in Shreveport. Dr. Ogundeji is a addiction psychiatrist trained at Drexel for his psychiatry, went on to Albert Einstein, Bronx, Lebanon for his addiction psychiatry fellowship, and went to UAB for his master's in public health, University of Alabama, Birmingham. Undergrad was in medical school from University of Ilorin, Nigeria, and he's been here in Shreveport area for the last 6 years. He's married with his children, and he's also an associate pastor at his local assembly, but he's an addiction psychiatrist, and he's on this show to help educate us. We talked last time about, opioids, alcohol. We talked about benzos, ADHD stimulants. I wanted to bring up tramadol because it's a lesser known addiction medicine, but it does cause some addiction.
Addiction.
So you treat it the same way you treat the opioids?
Yes.
Okay, interesting. What would you say to people who have excess pills at home and they just they take more than they need? What would you recommend to those people? Keep it, throw it away, substitute it? What do you think they should do?
One, it's not safe to keep a lot of medications at home. One, for your own safety and for the safety of people who live with you. Doctors change medication at times. Some insurance will tell you they do 90-day supply. After 1 week, they change it. And you keep them at home, and you find out a grandchild who might be mad at a computer game that got spoiled can go into the closet and overdose on some of this drug. We've seen people are dead from using other people's prescription. And then when you keep some of those drugs, some of them will have expired and you're looking for something, you take it, or you feel this is not working and you're mixing it with what the doctor has really stopped. So there are ways in which you can safely dispose or use medications. One, you can return them to the pharmacy. The police system will collect them from you. One, is not safe to pour your medication in like the toilet to flush it. It gets into the water system. Some of them are not good to drop in the dumpster because animals get to eat and things like that. So it's not safe to keep such medications at home. Whatever you don't use, you don't need to keep them.
How did you develop interest in addiction psychiatry? I understand, you wanted to be a psychiatrist, but then addiction psychiatry is a novel, rare specialization. What pushed you into that direction?
As a Christian, I think I follow the Bible principle that says everything works together for your good. When I first started my residency, I loved addiction in my first year. And because these are people you could relate with, these are people that you could get back on track. You see people dropping out of law school, med school, people have a house because of addiction, they've lost everything, or gambling, and you can walk them back and they can start retracing their step. I had interest in it. But along the path, because of the rate of readmission, at times they say somebody will have almost 12 treatments before they can really achieve sobriety. You see people, they are clean for 3 months, they fall off the wagon, they come back. And at a point, I lost interest because of the rate of readmission. I decided to go into public psychiatry. When I was accepted into NYU, I found that that won't work with my visa status. So I have to look for something quickly, and I went.
Public psychiatry.
Actually, there's public
It's
psychiatry.
a subspecialty of psychiatry.
Yes.
What
And
does
it's
that
more
mean?
of administrative
Oh,
psychiatry.
okay.
They teach you how to run programs, how to create, get grants, and all
Okay.
that, like
Okay.
business administration of psychiatry. So I went back to addiction, and I've never regretted going back.
Oh,
It's something
wow.
I do with passion. And one of the things that gives me gratification is going into the store. A patient I've seen 6 months ago said, "My family doesn't want anything to do with me." You see them in the store, they're so happy to introduce you to your family that have been doing good. It's 6 months now, things are working out. Oh, I've even gone to take care of my hepatitis C. I have a job now. My family is back and they love me. So
So we didn't talk about, I didn't realize you deal with gambling and sex
yeah,
addiction.
any form of addiction, people could be addicted to anything, pornography.
So you deal with that too.
We do on outpatient basis, yes. And you find out that because addiction uses the same pathway, the dopamine pathway in the brain, people are addicted to food, chocolate, it's all the same pathway.
And you use psychology and, if necessary, some
Yes,
medication.
to treat if there are comorbid obsessive compulsive problems with it.
Have you had cases of people with sex addiction
Yes,
and food addiction?
yes. Even with sex, I've seen one who describe classical withdrawal symptoms if she doesn't have sex in a day.
Okay.
And she had plans and all that. And later I really look at it that with the sex she gets endorphin release, which is natural opioids, and when she doesn't have that, she feels sick.
Wow. And she got better after the therapy, God willing. How about gambling? What do you use? Do you use
It's more of,
benzos, or do you
No.
just, okay,
You-
psychological?
it's more of talk therapy, one.
Okay.
Two, you find out if there are comorbid psychiatric problems, which you would treat. And then you refer them to Gambling Anonymous. There are programs, rehabilitation program where they can go to. And in very severe cases, you involve the legal system if they are really willing to stop addiction. People can go to the police station and explain their problem, and the police will get them on the list of those who are not supposed to be at the casino. So they ban themselves from the casino. So even if the urge is there to go, if they show up in a casino, they will arrest them. So that's the last resort, because some people, if they make money now, they are running to use it on gambling.
Okay. So you have some, let me not use the word control, but some guideposts and, people who can help keep them
Yeah,
accountable. Okay. Who are the best candidates for accountability in an addiction patient? Is it their family?
The
their
closest
spouse,
person to them.
The closest
This person. We always encourage them to get what they call a sponsor, which is like a mentor. When I'm discharging somebody from the hospital, I'm like, you need to get a sponsor. A sponsor is somebody who has been in your position before, but is now sober. Who understand what it is when you say you're having cravings to use or your urges are high. Somebody you can relate to. If you're in the military, you get somebody who has a military experience, who understand that maybe the nature of the stress of your job is what is causing you to use. If you're a woman, you're married, you want to get your sponsor to somebody who is older than you that you can look up to, who is also maybe married. If you're young, you don't get a family member, because there is a thin line between being a friend. Your friend should not be your sponsor, should not be your mentor, might not be frank enough to tell you. This is somebody who is readily accessible to you. You can call anytime, they can check on you, can distract you when you're having the urge to use, and it works. And the goal is for you to, after some years, become a sponsor, so that you know that some people you're accountable unto them, and the circle keeps going.
Tell us, if you want to be an addiction psychiatrist, what does it take? Maybe some young kid is in high school and he's like, I like to be an addiction psychiatrist. How many years did it take you to get there? Let's say post first degree.
Post-first degree, you get your medical degree.
Hmm.
Then you go for your residency in psychiatry. That's the basis,
That's
and
3 years.
4 years.
Oh, the residence is 4 years.
4 years for
The medical
psychiatry,
school is four
4
years
years
too.
too.
So.
And then you go into your addiction psychiatry training. There are 2 year fellowship, there are 1 year fellowship. The 1 year fellowship is more of clinical training where they
Okay.
ask you to treat patients. If you want the 2 year, you do 1 year of clinical and 1 year of research. And that will be your 2 years. And after that, you can start addiction. And with addiction, there are different concentration. You can decide to do the fourth stage, which is detoxification. You can decide to work in a rehab. You can decide to work in a sober living. You can decide to work in outpatient, partial hospitalization, maintenance, agonist program like the methadone program, the buprenorphine program. Whatever you choose, you always have people to work with.
Apart from the buprenorphine, is there another detox for opioid
Yes,
patients?
methadone and clonidine. Clonidine is the blood pressure medication, but helps with all the withdrawal symptoms except the aches and the pain, which we do give other
What's the
analgesia
other
for.
name for the buprenorphine? I don't know.
Suboxone,
Suboxone. Okay.
so,
So most people call it Suboxone
substance
Clinic.
clinic.
Yeah. So there's no other pharmaceutical equivalent apart from Suboxone.
There's Suboxone and Subutex. They are the same
Same
thing.
thing.
But Subutex does not have naloxone. The way they make Suboxone is they were looking at people abusing it either by IV or using it through other routes. So there's naloxone, which is a full opioid antagonist that
Okay.
has poor oral absorption, so as to reduce the rate at which people will misuse it.
Because I'm asking because if somebody says I can't tolerate Suboxone or buprenorphine, so they are stuck with clonidine and
Clonidine is for the
the
detox.
detox.
Yes, most of the people can't tolerate Suboxone might be because of the naloxone.
So they
They
may
might
need
be
methadone.
they might be able to tolerate Subutex, or they might do a methadone taper.
Can you become dependent on methadone or Suboxone?
Yes, that's why most of our clinic people are getting addicted and not making progress with it. It's been shown that most of this clinic works well when there's associated therapy and counseling with it, setting goals with people, rather than this is just an alternative. Take it, there are opioids as well.
Mm.
People can, but if people are motivated, they have counseling, they have goals and all that, they can stay on it for some time and start coming down gradually on it, because you use it after some time, you develop tolerance to it, then you begin to use more than prescribed. So
Okay.
it's just a lesser evil
The
at
lesser
times,
evil.
because you're not sharing needles. The risk of HIV transmission, hepatitis transmission is off there. You have a counselor you are supposed to talk to.
Mhm.
You can get jobs and all that.
Wow. Tell us a bit about the Masters in Public Health. Some of my viewers have that. How did that help you in your medical training?
I concentrated on epidemiology,
Okay.
which gave me a clearer picture of the burden of diseases. And I still apply that to what I do clinically, because I had infection control team in my
In your
hospital
hospital,
now,
okay.
using the public health knowledge on how to
Mhm.
prevent diseases. Disease is more about,
And it helped you with COVID as well.
yes, the disease is about preventing diseases rather than waiting till when people are having complications. Even with addiction, getting kids in the elementary school to know the dangers of getting used, how to say no to this, how to screen them, those who are at risk at early ages. So as
Was
to,
that why the American Academy of Pediatrics stopped the use of, I thought it was morphine containing, there's some dextromethorphan.
yeah,
They stopped it in under 6 year
year
olds.
old, yes.
So that was the reason,
that's
addiction.
bad addiction
Really?
and the risk of respiratory
Overdose.
dose.
Yeah. Okay. So it could start that early.
It could. I have kids who tell me they've started. I've seen someone say started smoking cigarette as early as 5. They smoke in the house. Oh, I drink alcohol. My grandmother drinks alcohol and she gives me. Even as a kid, that's the only way I sleep and all that. So you find out that because of that, they get hooked on it at a early
Wow.
age.
Wow. Wow. Now, tell me a little bit about in the addiction psychiatric field. compare the number of African American physicians with the number of African American patients. Do we see more African American patients in this addiction medicine as patients, or are there more African American physicians in the addiction? So is there a corollary in terms of cultural competence? Because a lot of people come to the doctor, they want to see somebody that looks like them and talks like them, and so is that something that is absent or present in the addiction psychiatric field?
Unfortunately, with addiction, it cuts across all races. Just that you find out there a higher rate of a particular drug in a race. The Caucasian might be more likely to abuse this, while the Caucasian might be like more, the African American might likely abuse this. But the stigma and the reason to seek help is different. So you see that, for example, the Hispanic race doesn't really come to seek help. Not that there's no addiction problem there. And unfortunately, there are few providers. But with addiction, what we do to reduce that racial difference is incorporating, working as a team, incorporating other people, nurse practitioners,
Right.
addiction counselors into the treatment. So if like my counselor right now is Caucasian, so
Right.
and we try to make having ladies not to make it sex biased. That is more of men. We have male and female working together. We meet with them as a team at times, so that gives them that privilege
Sense
of
of
knowing.
belonging, right. How about Native Americans? Have you ever been to I know there's one in the central part of Miss Louisiana. Do you see any cases from from the Native American community?
I've seen, and especially with the mixed blood, where there's a high rate of alcohol dependence in that
Okay.
population. They have some genetic
So you think it's
predisposition.
genetic?
To them, it's more of genetic predisposition.
Oh. Is it locally brewed alcohol, or is it like the regular beer, wine? Because I thought some people said it was from what they used to make. They call it shine,
It's
moonshine.
moonshine.
I don't know if anybody still does that.
People
People
still
still do that
drink moonshine.
in the
It,
homes.
yeah, I've worked people who drink mouthwash.
Really?
Mouthwash, most mouthwash are about 75% alcohol. And if you run out of money, that's how you know a true alcoholic. And sanitizers, you mix it with drinks, and people go to dollar store and get a big jar of mouthwash to drink when they run out of money to buy liquor. People drink vanilla extract, things that have high content of alcohol.
Wow, that is amazing. All right, talk a little bit about general psychiatry. So you talked about addiction. In your general psychiatric practice, what do you do, and who do you see?
I officially am, so as a general adult psychiatry, I'm to see 18 and above. But I just recently got certified in adolescent psychiatry
Oh,
this
really?
past August, because
Congratulations.
I'm seeing that a lot of this problem are starting in the early and late
Early
things.
years.
So it's easier to catch them at that age rather than waiting till their 20s. So the earlier, the better the
Right.
outcome. So people have different sorts of problem, which I don't even say. People like, I think I'm crazy. I don't have that word in my dictionary. You have some problems at this time. Your mind might be playing games with you, and people tend to accept that because most people know in the society, if you see things or hear things, something is going on. So people won't tell their family member. They would rather be numbing themselves. I've worked with a young adolescent who says she hear voices and see things, but she decides to use drugs so that she doesn't get fearful when she begins to. That takes her logical senses out. So normally if she hears things and see things, she becomes so worried and mom doesn't believe her. But when she uses like mushroom or any other thing, she floats in the air and all that in a relaxed way. And until we can take care of the psychosis, there's no way she will stop using drugs. So, and psychiatric problem could be as little as just adjustment disorder. An adjustment problem could happen with good things. You might be promoted at your work and the workload seems to be too much. You're getting more anxious. And instead of talking to somebody about how to handle things better, people can get married and becomes anxious. The birth of the baby, The death of someone, being diagnosed with cancer, being diagnosed with a chronic illness can stress
Trigger.
people out. So with that, and people with trauma, until you deal with it, people losing loved ones, depression, anxiety, those are some things that we do as general psychiatrists, not just psychosis or schizophrenia. We help people cope with life stresses. And most people who use drugs, or many of the people who use drugs, is that they have poor coping skills. When things don't go their way, they have an argument with their parents, they just go numb themselves. We teach them healthier lifestyle and how to relax without using drugs.
So in terms of your general psychiatric practice, do you think schizophrenia is the number one, or bipolar, or depression, or anxiety, or
To me, all of them are important.
but the most common?
Common. The most common is major depressive,
Just major depression, okay.
disorder. It's very common in our society, and bipolar as well, anxiety and PTSD, and I see a lot of cases of schizophrenia too. And what has actually increased the rate of schizophrenia are more of the drug-induced psychosis. Many of the newer drugs are causing permanent damage to the brain. In somebody who is healthy before, and all of a sudden they just change and can't go back to baseline.
And you still see some geri-psych
I do.
patients, some geriatric psychiatric. What are those people coming in mostly for? I mean,
Most like
dementia.
dementia-induced
Okay.
behavioral problems, medical.
So you
major
take care of that too if you
I
need
do,
to. Okay.
yes.
Wow. So you see a lot of. Do you see bullying cases, like kids in school being bullied, and they are having post? I don't want to use the word post-traumatic, but they are traumatized.
Acute stress
Acute
disorder,
stress,
and
right.
they react to it differently. One of the major problems is that parents and kids at times don't see. They walk in opposite direction. The kid goes to school in the morning, the parents are back from work, then they go to work all night. And many of these kids are being bullied in school. There's nobody to talk to. And at times they just look for a way to seek for help, which we say you're crying for help. They hurt themselves until people threaten suicide, or they start cutting or harming themselves for their parents to pay attention to them. So if we as parents could spend more time with our kid, ask them how their schoolwork, not just what's your grade, what's going on in school, what's going on in the neighborhood, is the uncle or aunt I'm living you with treating you well, rather than just believe nothing can happen to you, is my blood brother, is my younger brother, will take care of you.
Do you believe the statistics that say 40% of pastors are depressed? And actually, the statistics say that about 5 to 10% are suicidal. So an average of, I don't know the numbers, but a lot of pastors actually commit suicide every year. I mean, it's hard for us to see that from our point of view, but you are in the ministry, I'm in the ministry, and we know people who have actually gone through that. So
One of the major problems is that there are some depression that are situational induced, and there are some depression that are endogenous. The pastor could have either one of those. But the problem the society has is that they look at the pastor as being high up, and they can't share their problems. And you find that most pastors don't, their church members look up to them. They don't really have people to talk to. And at times that's why some of this depression. I remembered in 2006, I wanted to talk to one of my colleagues in med school. She's still in UK. And I called her. I wanted to explain that I was just getting out of the hospital. I have IV. She said, keep quiet. You can't have that. She didn't
have what? Oh,
she didn't even listen to find out what happened. She just said, you rebuke it, it's the devil and all that. I was trying to say that I was sick and this and that. So I guess the stigma of a pastor just saying, maybe you have a therapist in church that you want to open up to and say, I need counseling, I don't know how I'm
people
feeling.
might stigmatize the
pastor. So that makes them quiet to themselves until the point of
and they
becoming
shut down.
overwhelmed. Yes.
Right. Yeah. Even though they have everything to live for, a pastor in New Orleans killed himself because when they publicized this list of people who were looking at a pornography website, his name was there. And he had I think he was a lecturer at the New Orleans Theological Seminary. And they just published the list that night, and he committed suicide that very night. And his wife was like, I would have forgiven
Given him.
You know, it was like, why put everybody through this, you know? But I guess the shame.
People react to news and event differently. Maybe if we are taking a minute back and look at options, and also the role of mentorship. A pastor too should have somebody ahead of him he looks up to, you can talk to. Even with psychiatrists, they recommend you have somebody you talk to when you feel overwhelmed, when you feel the burden is too much, when you can't. You talk to somebody and the person can guide you. The person can watch out for you. Oh, these are the signs when I'm depressed. These are the signs when I'm under stress. And I think I'm seeing those things. You will need to talk.
And they say 50% of doctors burn out. So tell my colleagues who are watching, the family physicians, internists, anesthesiologists, I mean, how do they avoid burnout?
One of the things is that you have your schedule planned. One thing I do, I stayed at work a little bit late, but I complete my work and I leave the work at work. When I go home, it's my family time. When I wake up in the morning, I start the next day. But a lot of us, we bring the burden back home and all that. Yeah, start affecting us. Then time for vacation shouldn't be time to plan to do extra. It's time to relax and rest. And when you know you're burnt out, we are all human beings. I have colleagues who tell them, I can't carry more than this load at this time. I don't want to.
Why do you think some particular specialties have addiction problems? We hear the story of anesthesiologists. I don't know which other, pain management maybe.
I always make a joke when I have, because I've treated some of them, and who after recovery wants to go back to that profession. I was like, in my culture, we say you can't keep fried fish near a cat.
Okay.
Cats like fish. So if your job predisposes you to holding those medication, administering it, you're constantly punishing yourself. And after some time, you will relapse again.
Wow.
Some people, especially you find out, you went to med school, you shouldn't have addiction. These are people, if you take a good history, it might be running in their family.
So exposure triggers it.
It triggers it. So you can't be an ER nurse if you have addiction to benzos and opiate, because that's what you'll be administering all the time.
We're going to be back on the last segment of our show with Dr. Femi Ogundeji. You don't want to miss it. He's going to tell about his experience moving from Nigeria to America. Join us next week. Jesus is Lord. Amen.
Amen.